Again, I'd like to thank all of the speakers, but also those who have attended today to the session. We hope you enjoyed and found value in what was shared. I'd like to open the room to any questions that anyone might have. Yes.
Yeah, I just have two practical questions. Number one, how do you maintain the tube inside the different room? Because as you start your machine, you're going to infuse the current in, right?
Yes.
So is there a possibility that the tube plunges this one out?
Yes, that is a great question. So this is a demonstration kit of the device. So there's a few mechanisms. The first one is that there is this retention sleeve. So the retention sleeve sits flat against the stoma wall, and then it will. And it also there's a clip. There's a clip that that tethers the tube to the outside of the bag. So this tube, this clip tethers the tube to the outside of the bag, so it creates a connection so that it keeps the tube warm. We recommend that the tube is inserted just past the fascia as well, and it's kind of like a mallet box, so it's not a wound-related device. So once it's inserted, and then faceplate protecting piece sits on the wall, and then the clip tethers into the bag, so it creates strength as well.
Exactly. The technical thing about this is that the tube is, this part here.
You won't bend out, right? So
Here, one part. Something like medical or the accent, something like that, right? So first, you will decide that this is an infant loop. You do a per exam, per stoma examination. You put finger inside, depending on patient. Some take abdominal wall, some clean abdominal wall. You put your finger, make sure that you in a way roughly know how long is the length. See, the thing about this guy is that it is adjustable. So in a way, this in a way keeps it in that position and angle it downwards. So you do a per rectal examination, per stoma examination, feel and know roughly how long. Put it more than that first, you push inside first, and you tuck it up.
yes, you have many sizes, right?
Yeah.
Two sizes.
A 22 French and a 28.
22 and 28 French. So in a way, you per stoma examination, knowing how much, push it inside, you tuck it out, then tuck it in a way, but don't pull too much. Give it a bit of speed. Because the useful thing is that when this thing goes inside, this clip is actually very useful to hold the place. I mean, the other practical thing that the advice given by Professor Bissett is that before you do the where to insert, yes, during surgery you already decided this is apron, this is apron. So during when I first started off, he said do a contrast study from here, so that you know that it goes some obstruction. After a while, after this case, I don't do that anymore because I create the stoma to make sure it's all right nicely. I do my finger examination, it's okay, then I just to the side, and then I'll start beginning. At the beginning, you know that because of diversion, colitis, usually these different pattern indicators, you get infarcts. Is that a guideline on how I sometimes say that it's actually the good thing. After a while, they know that it goes slow in the pump. You start with 20 first, 30 first. You let the edema, the colytic process to so-called undergo resolution. Then you can put in some more faster. Two sizes, 28 and 22. Yeah, 22, right? Mm-hmm.
How far in do you recommend you put the pump in from
Just a skin abdominal wall, fat abdominal wall, right? You just push it inside, you tuck it up, but don't tuck too much because sometimes you open, just pull it out. To me, it's a try and error thing, right? To me, just pass the abdominal wall, not too snug, give it a bit of space, put it inside,
Below the rectum.
Below.
Why do you need to snug it? Why can't
No,
you
I'm
just
just
leave it
saying,
long
when
enough?
you put it up, you know roughly where you want, then you push a bit more inside, then you
Okay.
get
So the longer it is inside, the better it is actually.
in a way, up
Yeah.
to the patient sometimes in a way, yeah.
There's a limit of length.
Yeah, of course, that's maximum. And what's the maximum thickness of effluent that you can push back?
So there's actually 5 different speed settings. So 1 is your slowest and it goes up to 5. So 1 is what we call water thin climb, and 5 is for your much thicker climb. So as we know, once we start introducing distal material content, the valve adapts. We see that the viscosity does increase. So one test that we actually ask our clinical team and even the patient to do is the pinch test. So if you pinch the bag and there's a climb falls back into place, that is still for manageable viscosity. Of course, if it does become a bit too thick, we actually do have an accessory now that enables fluid to be administered into the bag to help. Yes, so to dilute the contents a little bit. And so,
How should we get that?
so if it is a patient, so if it's a fistula patient, generally we would need to resolve sepsis and make sure that the wound is manageable. So it's more of a wound care. If it is a patient that has had a colonic resection, then generally we would say it would have to be probably 2 to 4 weeks for the anastomosis to heal before you do a contrast, just to make sure that it is ready. If it is a small bowel resection and the clinical team is comfortable, then you can actually start when you think it is ready. So it depends on resolving the other complications first. And Prof. Chong can.
It's a clinical question. Once you start, is it just like, okay, usually these kind of patients are not elective surgeries, right? Not those good ERAS protocol, start feeding next day and things like that. So, once the bowel starts to move, just like we're giving trophic feeding, for example, I mean, you can also do the same thing with this, right? You know that when you create it, already edemators, especially those of shorter kind of thing, you wait for this to resolve a bit before you feed it. The bowel function, we go by clinical. I mean, like that, like my second case, all the way one. By second week, I actually started it already. Go slow. The advice said, you said, first start 20 minutes, let the patient get used to it, 20, 30 minutes first, right? The time is that for the patient to get used to this process, to this thing. And also is that because when you feed inside, we feed inside there, because of the edemators stiffen efferent loop, sometimes they tend to reflux out. Okay, so just go slow. And patient after a while, I say when you sitting down there a bit, get practice, do first. Strictly by 20 minutes per day, 1 week, then 20 minutes BD and things like that. I think sometimes we go a bit slower. So I motivated patient. I said, just give a bit. I mean the 5 speeds, right?
5 speeds.
5 speeds, yeah. Sometimes the American John, they put 5 speed and then go inside and come out again, right? You teach them the mechanism. Actually, patients are quite motivated. Actually, can do this. Some also telling us that.
We always recommend using the slowest speed possible that gets it up, because once you use a much faster speed. So we actually, for example, we had a patient in New Zealand. She was 19 years old. She was involved in a motor vehicle accident, so seatbelt laceration. So she was very motivated, but she was too excited because she had been in ICU and TPing for such a long time. So when she started the device, she was so excited to use it. She went to speed 5 immediately, and that caused discomfort. So we want to minimize discomfort, especially when they're first starting, and especially if they've been defunctioned for a long time. So small boluses for the first few days, and then move up from that slowly once the valve becomes rehabilitated. And the slowest speed possible that gets the content up is enough. You don't need to go any higher.
Yeah, that's true. And warn the patient about you'll start having bowel output. They should be happy, right? After a while, is that when you started recycling more, then you'll start having diarrhea, right? Warn them, tell them beforehand that this can happen, so that they know, that they don't think that it'll go to normal or pass motion like normal. You have to wait for the adaptation process to happen.
What is P1 to 5 in terms of yields?
Because it's time, so there's no flow rate. Yeah, it's just the mechanical speed setting. Yes.
One question about in terms of medication, did you try to alter with the loperamide? But is there restriction in that or just continue off it?
Yeah. Then again, length is one, the quality of bowel is two, am I right? And also the patient's sepsis, parotid ileus and all these things. If you want to do kind recycling, right? Again, at the beginning, if the patient is coming out a lot, for example, and you know that you got 150, 200 centimeters of small bowel, and they are good quality, no problems with all these kind of things. And I actually try pharmacotherapy first and try to slow it down. If things are okay, I'm going to do the recycling, right? Like that patient that 240 cm, I said malignant obstruction. The one is that I just prime the patient that now that I created this, you'll be okay. You might have to recycle because your irradiation and your systemic therapy and cause you diarrhea and things like that. But we have this device and we get it ready for the patient because this patient, in a way that can't wait for too long, right? You try oral medication but still high output, I will recycle. In a way, because in Singapore is that when you're in the hospital, the bill goes into his inpatient bill. So we buy beforehand. Let's say this patient is discharged and in the outpatient setting, it comes from the pocket.
So meaning that the moment that she's on the system, then we can off the loperamide off.
No, it depends. If let's say the maximum loperamide, Lomotil, the whole works, codeine and everything still not working, you know that, okay lah, this is not working already. You have to do kind of recycling. In a way, I slowly slow them off to a certain amount, not too much, not too copious. Won't have at night your back is full and things like that. I still continue that. There's no one recipe for every single patient. That's the problem with this.
One machine for how long? One machine for how long?
One machine. So there are three components. There is the tube. The tube is inserted changed every month, so 28 days generally by a trained health professional. The impeller pump is what connects at the end. That is changed every 2 to 3 days. So that's done by the patient every time they do a stone bag change. And this driver is a single patient use device, so for however long they're on therapy for. So it comes with the charging kit and everything. So.
Special battery, is it?
No, it's just a normal battery, but it comes with a charging adapter. So the initial starter kit that is provided. So you just charge it like your phone, really. It packs around 2 to 4 weeks of battery life or a full charge, depending on how frequently you use it. It takes about 4 hours for a full charge from empty. So patients generally charge it bedside when you're not using that.
One piece of advice to the company is that I think that thing can be a bit difficult to hold for a patient in this position or in this position. And it's a bit smooth and it's a bit heavy. They should have a strap to the hand because I dropped one before.
I think right now the starter kit, the first month, which includes the pump, the driver, and the tube, is 7,000. Every subsequent month, which is only the tube and also the pump, it will be 5,000, depending on how many months they do. If you go according to the guideline of the recommendation to replace like every 2 or 3 days, it will basically last you for a month.
Sorry, the pump has in the impeller
Oh,
device.
I see.
Yes.
I'll ask one question. More practical. Sorry, junior around that. Because all the example I saw is most of the cases is the inference and inference is quite minimized. So most of the cases that we encounter is the ankle radius fistula is that we have a big gap between the difference and the inference. So is this still doable for this device, or we need 2 devices, or we have to explore it and bring both ends nearer to the
So there is actually a device that we launched last year. It's an accessory to the Insight system. It is called the Insight channel. So it allows the bridging between separated stomers. So we've created a way to connect. It currently works with high output bags right now, but it's designed in a way so it connects the two ends of the high output bag, so you can channel. So for example, the proximal would you'd re-infuse the proximal content into the second bag, and then just like how you would usually re-infuse the content back distantly into the second bag. Yes. Transfer, yeah, it's a way to transfer it.
If it's in the midline, you have two holes, two stomas, or afferent is in the midline wound. If they're, I cannot say how many centimeters together. So use your vac therapy, bring in, try to close the wound, and then a good big stoma bag. Yeah, then you can collect everything and then pump it back inside in that sense. Okay.
Basically, I think for interpreters, you need to know how to manage the barrier. That's where your stoma nurse needs to be also involved. Because when you have fistulas, you must also know which one is proximal, which one is distal. Are you going to be able to connect these two into one bag? Because the main thing is to connect into one bag. Because right now the pump is the whole system is going out and pushing it back in within one bag. Now, if you're able to modify the wound dress in such a way that you can bring them together into one bag, that would be you need your stoma assistance. Then you should be able to do that. But provided in fistulas, you must be very sure that your fistal loop has no obstruction. You must be very sure about that before you use it. Before entering.
No.
Mr. Hans, you have anything to add?
One question about this. Is it covered by JPA, or how do we do the importation who cannot afford this in the social welfare?
Cancer, I think, try to work out with partner. We currently have one case we're working out. For benign work, JPA depends, like it's justified well, you could probably get that ALS because now it's already registered.
Usually for GPA, either disebutkan atau kerajaan boleh buat boleh bersara ataupun yang masih bekerja ST perlukan ada GPA lah. In our hospital, I pernah advisekan that MAH also be MAH, and then untuk makna kita belum try lagi. Makna because Johor got yayasan, so that one pun belum. So for kali I dah pernah apply under JPA and MAH. So for the dua tu.
Makna will let you know whether it works because you are applying for one.
Yeah.
Will let you know whether Makna.
The justification, like, get the paperwork done well. That's why she's the best with paperwork, and that's my boss.
Zakat is another option that you need to think about. Especially, I think now they don't give for cancer patients, but anything besides cancer, I think zakat.
Yeah, MAH and zakat actually under one.
Oh, I know, but
But the thing is, just one small note for the effort. You don't want to give too much locromide because then the effort becomes thick. So usually, once you start primary infusion and you've got it done well, you have a zero loss system, like what she did. I actually stopped the locromide and kept it liquid, and then it just stabilized. What happened to Sampot? He wasn't swallowing. Because at the worst, he was swallowing what 20 milligrams of locromide 3 times a day. You go high dose locromide or shock bowel, you go very high dose 20, 30. Once they get cramps, you minus 8 milligrams of the dose. But that's troublesome for them.
Yeah, so
I'll just keep quiet. You all know better.
Yeah, with that, thank you very much, everyone. If you still have any questions, you can always come by to our booth. Thank you.